Happy to have Dr. Muir with us today. At DCRI, he's the Director of Gastroenterology and Hepatology Research. At Duke, he's the Chief of the Division of Gastroenterology in the School of Medicine. His research is largely focused on developing innovative treatments for a variety of liver disease, including he's worked on many of the agents that have revolutionized Hep C care. He has research interests generally in viral hepatitis, liver transplantation, and something I can't pronounce. Primary sclerosing.
Oh, yeah, that's right. You're doing fine.
That?
Cholangitis.
Cholangitis.
Right,
I should have just gone with it. And he also has a long-standing interest in healthcare disparities. So he joined the faculty here at Duke in 2000, and like all of our faculty, right, he's been very productive, publishing in distinguished journals and winning many, many teaching awards. So we're very happy to have him here to talk about Hep C at Duke. Thank you.
Thank you, Brad. Thank you all for coming. I realized I picked a date which was during a GI meeting, so that was really smart. But I thank you all for coming in, and here's your CME credit thing. So we can really cure hepatitis C now, so I wanted to talk about other things around that, and I'll kind of walk you through it. These are my disclosures from actually the research that's really done mainly in this building. So what I thought I would do is actually, I'm going to do a little bit of a history lesson. There's a lot that's happened in this field, and a lot of the folks who work in this building, and I guess now our other buildings, I should say, also participate in all of that. And I think I've learned a lot, our field's learned a lot, and I wanted to talk about that. And I wanted to talk about then current Hep C treatment and what we're doing, and then all the stuff around it, like what we can do with these drugs now that we have these really potent medicines that we'd like to help people with. So here's where the history lesson begins. In 1989, I was a first-year medical student, and hepatitis C was discovered. It was known that there was something going on in the blood supply, and there was this non-A, non-B hepatitis, but this is the first time they actually identified it and knew what, and could put a label and a name on it. Came to learn that it was this RNA virus. There are 6 main genotypes. Sometimes we think there are 7, but largely there's 6 genotypes of it around the world that we try to address. So 1992 is when the blood supply was effectively screened for hepatitis C. There were some early tests between 1989 and 1992, but those weren't so good. So 1992 is when the blood supply is reliable in the United States, I should point out. The rest of the world, not so much. But in 1992, we had it. And this also is when then testing becomes available and identifies where Hep C is throughout our society and throughout the world. And I put this graph just to sort of show you where it is throughout the world. The darker colors are where there's more hepatitis C. You see that we have a moderate amount in the Americas. When you go to Asia, we see more. When you go to Africa, we see a lot more. Egypt is the one that really steps out there because they had a vaccination program for schistosomiasis, and through that vaccination program, they basically spread hepatitis C. So between 15 to 20% of their adult population has hepatitis C. That's why if you hear a lot about treatment programs in Egypt, it's because of that. It's a little bit of a weird thing in Africa. I find that the countries that were wealthier earlier had more Hep C than the countries that were impoverished. So if you didn't have much of a healthcare system, you couldn't really spread hepatitis C. But those who had healthcare systems were able to spread it. So we'll come back to that. So 1998 is when hepatitis C treatment enters clinical practice. Some of you will notice the author of this paper is John McHutchison, who established the program here at DCRI. Prior to this, there was some interferon treatments. I was thankfully not in practice for all of this. This medicine is very toxic, and you'll see that what they did for about the first 15 years was treat people with a less than about a 10% chance of being cured. This is an injection people were giving daily or 3 times a week. And then when they added in this medicine called ribavirin and extended out the treatment, they found they could get people up into the 30% range. And that was enough to have broad treatment in the United States and Europe for hepatitis C. For it. So I put a boxing match in here because I feel like 2001 is when it became pegylated, and then we had basically war between these 2 drugs, and we spent a lot of that decade trying to figure out which of these drugs is better, and it was a lot on it. It was an interesting time. But with both of the drugs, there were issues with it. So basically these were injections that people took once a week. They had lots of side effects with them. Many patients could tolerate them, but they would have pretty significant flu-like symptoms. People worked, they were able to keep working, but their lives were impaired by them. They had cytopenia, so the blood counts went down, those kinds of things. One of the bigger problems was too few patients were eligible. If you had significant mental health issues, people couldn't take it. If you had significant lung disease or heart disease, people couldn't take it. The flu-like symptoms they're the real flu-like symptoms. They would essentially tip you over into pretty severe distress. And people with depression and significant depression and anxiety would get quite ill, mentally ill. And so successful suicides were reported with this. So we used this, we monitored all these people, we evaluated them, we wanted to see how they were doing. But we knew that in reality that we weren't really treating the entire population with it. And we thought the response rates were pretty good, but as I'll show you in a little bit, they were low. but we thought they were great. I'm going to take a little bit of credit. This is what got me tenure at Duke. I started here in 2000, and I was asked to start a hepatitis C clinic. Pretty quickly, there became a debate about whether African Americans responded well to hepatitis C treatment or not. And one report came out and said basically they don't respond at all. And another report came out and said that was bogus. They were both retrospective things. So my mentor actually helped me, and one of the companies actually supported me as a fellow actually to do this, to start this project. And we did this observational study that showed there really was a difference. And this, I think the clarification on this, another study showed this pretty soon afterwards, led a lot of people to understand there was a genetic issue with hepatitis C and it required further study. Anytime you see such a strong racial difference in response rates, it suggests genetics are in play. So around the same, as we come to the end of this decade, the IDEAL study gets published. And this was part of that boxing war thing that I showed you before between these two drugs. And one of the companies had an FDA requirement to do another study. So they did a 3,000 patient study looking at the other medication and their medication and different doses for it to see which would be better. So all these patients had genotype 1. And at the end of the 3,000 patients, and I can only imagine how much money, it was a tie, statistical tie for it all. And so I will say, I got to participate in this study. We enrolled, I think, 120-something patients at Duke in this study, just out of our Duke clinic. A lot of our patients were treated for it. A lot of research has come out of this. A lot of outcomes work has come out of this study. We learned a ton about hepatitis C through this. The primary endpoint, though, was a tie. Probably the real legacy of that study is this, and this is another thing that this building takes a lot of pride in. So David Goldstein's lab was here at the time, and we worked very closely with his group. Up front, the company knew that genetics might be important, so they asked all patients in this study to be consented. And I think this was the first hepatitis C trial that really tried to look at genomics and went through the process of a separate genetics consent. We do that pretty routinely now, but it was, even a short time ago, it was challenging to know if patients would really do this. There weren't that many people of different racial groups in the IDEAL trial, so I had got DNA on most of my patients in our Duke experience, and so those were supplemented mainly to look at whether there was an African American signal or not. The end result is there was polymorphism near the IL-28B gene that predicted response. And what it shows, I don't know if does this work? Yeah. So anyway, basically, the people who had this favorable CC genotype, they did the best. And actually, if you were African descent and had that favorable genotype, you still did well. It didn't completely explain the racial disparity, it explained a lot of it. So it also showed that many of these people, whether of what racial or ethnic group you're from, if you had this unfavorable genotype, you are very unlikely to respond to this. So this, number one, it explained a lot about what had been going on, why some people were responding, why some people were not. It also was a call for we need better treatment. We have a toxic treatment that in a major portion of the population is never really going to work. So this only encouraged there to be more treatment to come. So this, what I'm about to take you through now is really in a short period of time. We saw a tremendous growth in this area. Drugs have come through very quickly, really in less than 10 years now, and it's been this amazing turnaround on treatment. This is the first drug that really, I think, became a blockbuster and really changed care. And the phase 1 study was designed in this building. This is actually a phase 2 study that really showed a difference. So this is telaprevir. This is a first-generation protease inhibitor, so directly targeting the hepatitis C virus and stopping it from reproducing. It couldn't be given by itself. Resistance developed really quickly. So we knew we were going to have to give it with the PEG interferon and ribavirin. So we still got the challenging side effect issue, but a lot's going on here. But what we saw is that when we gave it and we extended treatment out, we got over to 67% of the patients were cured. So this was very exciting. Remember, we started off in the teens, and then we got into the 30s, and now we're in the 60s. So we think we're pretty cool. This would be embarrassing now. So this was great, but a few lessons here. So, and I want to take a bit of a detour and talk a little bit about the DCRI HCV monitoring. So in the middle of this trial, we had a problem develop really quickly, and I felt like this was DCRI at its finest. So we knew that there was resistance could happen with this drug, and we knew that we'd have to watch for it. And if there were signs of resistance, the patients were going to have to come off the drug and stop, because you wouldn't want to continue to treat when resistance had developed. So a central lab had been commissioned or paid to do this, and I was the medical monitor on the trial. I was also unblinded to all of this, which the FDA wouldn't allow any of this now, which sort of shows you how much things have changed in a short period of time. But I saw all the lab data. I saw everything that was going on. And somehow I did not get interviewed by the SEC ever through all of that. I realized that it was dangerous for me to actually have that much access. But because I knew it was a billion-dollar drug before anybody else did, which was kind of cool and kind of scary. I also realized in the midst of this that there were patients having resistance that wasn't being monitored appropriately. Basically, the central lab that said they were doing this didn't do it, and they just lied. I mean, or didn't have staff to do it, so they weren't really monitoring it quickly. And we sort of realized that this was beyond what you really could expect to be done manually when you're getting up into trials with hundreds of people. And so very quickly we had to pull together, while the study was going on, how to do this. I will tell you how we do it now versus how we did it back then is different, but it's been a really nice evolution. And so what we needed to be able to do was large trials in the hundreds and thousands of patients, and monitor this for these rules of resistance based upon the study protocol, and make quick decisions. So take data in, process it, and get it out to a patient in a site so that they could, within days of getting a lab result back, they could tell a patient what to do. So Stephanie, I took this from one of your PDFs from years ago. So Stephanie, I think, put this together as far as you would have all this data come in. It would come in from the electronic data capture system. It would come in from IBRS. It would process this all together. Based upon what the study protocol was, there were rules that the system developed. And then the system brings out every day, up until today, it still brings out these decisions about whether a patient should go on treatment or should stop treatment, or what we should do. And it's been powerful. And I will tell you, many of the programs that have come forward have used this system, and it's made the data cleaner, it's made it faster, it's made it safer for the patients. We don't have patients going on with inappropriate treatment. A bit of a surprise that some of the companies liked it so much because it allowed them to track the patients better. Like, we could tell them when the patient was out of window, because we were worried that your patient hasn't had a lab. Are they gone? Are they? Why? What's happened with that patient? And so it's improved the performance of clinical trials, and later retention of patients became so important in hepatitis C trials, and this was a nice side product of this. So this, like I said, started off in this disaster for us, but by a lot of people coming together in the building, it really became, I think, a way that we, helped the field tremendously. And so there's a lot of folks in the room who can be proud of that. Back to the boxing match. So after we got telaprevir, then we got boceprevir. So then we had this brief period of time, we got these two drugs, they're great, they're curing everybody. Which one is better? We, again, probably spent too much time worrying about which one is better. But we did learn some things. So through the trials, like I said, the resistance thing was a big issue, and the viral monitoring program was key. I learned what people will do to cure their hepatitis C. So I started to hear about rashes with telaprevir. And this was probably around the first time people were really using their iPhones. And I know they shouldn't have done this, but I kept hearing that someone's having a rash. And then finally I got the picture sent to me and I was like, that's not a rash, that's a rash. And so I kind of had this vision of like just, mildly erythematous thing. And I was like, but these poor people were so desperate to get their hepatitis C cured. And for those you don't know, Stevens-Johnson and DRESS is drug reaction with eosinophilia and systemic symptoms, which is why we say DRESS. But this is a life-threatening situation, and while that was a low risk event or uncommon event, it was possible with this drug, but people were so worried about their hepatitis C that they were willing to take those kinds of risks. And so we had to, again, very quickly develop a rash management plan during the protocol to almost protect patients from themselves, well-intentioned physicians from themselves, because they were so focused on just curing the hepatitis C. But we didn't lose anybody, but I think we came close. And in Japan, I believe they believe a couple of deaths have happened with this. And but we learned, we developed a rash management plan. Still, even with again, we've got a pretty toxic therapy. It does pretty well, but still, people were willing to take it. In hindsight, it's amazing to me how many people took a drug that had a lot of risk associated with it. Then we go out into clinical practice. We learn more. There's a lot more drug-drug interactions. We learned that they didn't do a whole lot of drug-drug interaction testing before these drugs came to market. So that was, again, wow. So we had to, now all drugs get a lot better drug-drug interaction profiling before they come to market, but that was an issue in hep C. We had a lot of anemia. And then we had issues, as we went into clinical practice and treated sicker patients, we had issues with more of the patients having what we call decompensation. So that's if your liver's stable, but at some point you can go into like full-blown liver failure, and those are the patients who need transplants. So these were patients who were stable, doing well, but when treated, they progressed. And this is the data from it. And just to give you a sense, there were people who died. And at this stage of liver disease, people shouldn't have been dying. And people getting decompensation in the 4 to 5% range. These infections, particularly over here with telaprevir, these are not just having a cellulitis. These are pus in joints. These are meningitis. These are significant life-threatening infections. And again, but we were so aggressively treating people for it because we were so worried about their livers, but the bigger picture of it was escaping us a little bit. So, but again, this was probably there was a lot of conjecture. This is from a French cohort study. There was a lot of discussion. Is it real? Are they just treating too sick people? But I think this was another cry for we need better drugs. We need drugs that are safer, particularly if we're going to try to cure the world. So, I promise I'm not going to show you every slide, every study, because that would take a while. But I do want to show you some that I think really kind of changed how we think about it. So this is one of the first electron studies, and a company called Pharmasset that had an office in Research Triangle, where really a lot of, I would say the innovative group of Pharmasset was really in Research Triangle. So they designed this study. And I showed you where we got up into the thousands in hepatitis C trials, and we were so impressed with ourselves and thought we were becoming like cardiologists and having these huge mega trials. And they went the exact other route. They have 10 patients per arm in their studies. And they were really going for a big hit. Either you get it or you don't. And they did a number of studies like this with a number of different cocktails, a number of different approaches, and just looking at 10 patients. As basically, this is the test. If this works, then we'll go bigger. But they did this a lot with a lot of different things. So what they did here is they had this drug sofosbuvir. I was in an ad board where people said, this drug looks so good, it looks like there's no resistance, it's a polymerase inhibitor, it looks really good. Maybe you can get away without using interferon with it. At the time, this was borderline heresy. And so they looked at it with 4 weeks of interferon, 8 weeks of interferon, 12 weeks of interferon, or 0 weeks of interferon. And it worked for these patients. Every single patient in the study was cured. So it's one of the first demonstrations that we didn't need interferon, so we could get away with a much better side effect profile. So this is the same study looking at the genotype 1 patients. And see, if they'd never been treated before, they did great, or they did okay, 84%. In this one, if they'd been treated before with interferon, they didn't do so well. So this was a sign that genotype 1 was going to be tougher. We needed more, but there was enough here to go forward for 2 and 3. This is the other study that I think really set the wind on everybody's sails that this could really work. So we had these patients who'd failed boceprevir and telaprevir. We were very worried that there wasn't anything to offer them. we were worried about, we learned pretty quickly that if you failed those drugs, you had resistant virus. So there was a whole lot of worry that they were not going to do well, and were we just going to lose these patients to liver failure. And the FDA was getting pretty cautious about these patients. And so this study took 41 patients and gave them all this sofosbuvir, the drug I was just telling you about, this other drug, declatosphere, and then half the patients received ribavirin. They gave them all for 24 weeks. And this was really thought to be a Hail Mary. What do these patients have to lose? They're going to die anyway. You know, they weren't really that sick, but that was kind of the mentality. And all but one patient was cured. So this was, again, really showed everyone that this could really work. And we needed to rev this thing up. So then really the pace picks up really quickly in development. So by the end of 2013, sofosbuvir received FDA approval. For genotypes 2 and 3, it was without interferon. So that's our first time we've ever really been able to do that without interferon. Genotype 1 still needed that then. The other big thing that happened to us in 2013 was the FDA-approved transient elastography. This is a device that had been available in Europe for a decade. So my European colleagues just made fun of us the entire time. Basically what it does is it sends a shear wave through the liver, and then it measures the speed of the shear wave and turns that into, through a physics calculation I refuse to explain, turns that into a stiffness score. And a liver that has more scar and more fibrosis in it is stiffer than a healthier liver, which is spongier. So what we found is this is very effective to tell you if you've got advanced liver disease or early. It's not really good at telling you you have stage 0 versus 1 versus 2 versus 3 versus 4, but it's good at the extremes. And liver biopsy had been recommended, and we did a lot of them, my patients do fine, but nobody really wants to get stabbed in the side on a regular basis, and so it was really a barrier to care too much, and so this really expanded things out a lot. So now this stopped. I think this has made patients more comfortable knowing that a liver biopsy was not going to be something they had to go through to get hepatitis C cure. So that's helped us a lot. All right, so now we come to 2014, and again, there's a lot, pace is picking up a lot. There's a lot of enthusiasm for everything. This is the hepatitis C, a schematic of the life cycle. And basically, all our drugs are down here in sort of the translation process. We're trying to impact the viral replication. With we have protease inhibitors, we have NS5A inhibitors, and we have polymerase inhibitors. And we learned that targeting one of these is not adequate. So we've got to at least do 2, and some of the regimens do 3. The other, we looked at viral entry, we looked at some of the other things, they've been tougher to deal with, but these we have effective drugs for now. So this was 2014, and these were the regimens that were approved, available around this time. So sofosbuvir ribavirin was the first one, but again, pretty limited. Sofosbuvir ledipasvir is what you've seen ads on TV for. Then we have competition with paritaprevir, ritonavir, dasabuvir, and abitavir. And I want to point this one out. It's kind of interesting. So Semifravir was made by one drug company. Sofosbuvir was made by another drug company. They were both approved with interferon, but clinicians saw through a small study that you put them together, they do great. And so even though, again, we had, I think, study with 20 patients in each arm, based upon high response rates in that, this became the #1 treatment for hepatitis C for about a year, until these two got approved. And clinicians just went with it. Again, and patients just went with it. There was very much more aggressive patient interest in this. But based upon 40 patients in a non-FDA approved regimen, that became basically how hepatitis C treatment happened for, I think, 6 or 9 months or so. So I say some of these things just because the way the patients behaved and the way the clinicians behaved has been interesting the entire time. This desperation to get hepatitis C cured has been powerful. All right, so this is ledipasvir, sofosbuvir. This is the one you see on TV sometimes. And I'm not going to show you every study because there's a lot, but this is, and my main point here is they looked at this at 8 weeks and 12 weeks, with and without ribavirin. And if you go just to the top, however you treat them, 1A versus 1B, there's different strains, we're up over 90%. And what quickly happened is there were a whole bunch of drugs in the field around this time. If your response rates were under 90%, the regimen was shelved. And it was just unacceptable at that point. And we really saw a lot of, that's probably why there were less trials to do around here, because a lot of programs just stopped. And things really consolidated because the bar became so high. You had to essentially be able to report out an over 90% cure rate. This is one of the other studies from the other regimen, which is paritaprevir boosted by ritonavir with dasabivir and abitavir and ribavirin. And I practice that a lot. And so I'm very good at it, don't you think? But so this is a protease inhibitor, NS5A inhibitor, and a polymerase inhibitor all together. This was, I think, one of their more impressive studies. It's 380 patients. They all have cirrhosis. And they had some explaining to do here because they got to 89 in this one group. So that's a problem. The genotype 1A patients were a little bit harder. But again, it just showed you very quickly we went to very high response rates. And these are all generally well-tolerated regimens. In 2015, we had another drug join, decladisvir. And the reason I put this out, I meant that was the study that was in that one early on that showed that was some value. They did finally got FDA approval for this because genotype 3, which is not as common in the US, we have about 10 to 15% of that, but it is number 2 worldwide. Genotype 3 has become our toughest genotype to treat. We are at 95% or so in pretty much every genotype. And it's taken this regimen to get us there for genotype 3. But in patients with cirrhosis, we're still not there, actually. And so this is still our toughest genotype to treat. So this genotype is holding us back from being able to really declare complete victory. This is the latest entrance earlier this year, which is crisaprevir elbazir. I'm going to come back to this one a little bit later, but this is a couple of very interesting things about this study. Number one, high response rates were up over 90% for it as well. It's another very well-tolerated regimen. I mentioned a couple times we worried very much about resistance. The FDA hadn't really weighed in on this too much, but in this study, because there are some patients who have this resistant variant, they've actually now recommended that if you have a genotype 1A patient, you actually test with a commercial lab for resistant variants, and then you will make your treatment recommendation a little bit different based upon that. So it's really brought new discussion for us about testing for resistance and how we guide it. It's probably relevant to the other regimens as well, and it's making our field revisit all of this. GI doctors have traditionally liked things to be kind of simple, and this is not overly complicated, but this is something for us to work through. The other thing this showed us, we used to think that if you had one protease inhibitor, probably couldn't get another protease inhibitor again. This is because this has a better protease inhibitor in it. Even the patients who failed the previous protease inhibitors do really well with this one. And there's the other thing, I'll come back to it, but this is a great drug for patients with kidney disease, and we'll come back to that later. So what about all the patient groups that I mentioned that did poorly with interferon? How are they doing with all of this? So HIV Hep C is a group that we worry very much about. They have high rates of hepatitis C. If you got your HIV through drug use, you have a high likelihood of having Hep C. If you got your HIV through sex, it's less likely. So in the US, we have about 30% of people who have HIV also have Hep C. So, and they have faster progression of their liver disease. They have greater risk of cancer. We worry very much about this group and want them cured of their hepatitis C. The HIV and the hepatitis C play off each other. We need to get them cured. So Susanna Nagy, who runs ID here, has made her claim to fame in this area. This is the regimen with ladipizvir, sofosbuvir that she published in the New England Journal. And again, they saw that 96 to 100% rate. This is a group of patients that in the past we worried, in the interferon era, their response rates were lower. They were considered a special population. We were very worried about them. I could show this with every other regimen now, actually dating back to telaprevir. This group does great. There's some issues with drug-drug interactions with some of the HIV therapies, so sometimes we have to switch those things around. But this group of patients does great with hepatitis C treatment. So we want to aggressively seek cure for them so they can avoid any other complications. Their risk is greater. African Americans, again, that was what I was interested about. Julius Wilder, who'll be joining DCRI in July, has looked at this quite extensively. His PhD looked at racial disparities, and so I'm turning most of that over to him now. So this was looking at the sofosbuvir ladipizvir experience with two things in mind. Number one, in the past there were so few African Americans in research studies that you couldn't really tell a whole lot. Number two is how are they doing? If you just look over the numbers for the different arms and the different types of groups, you see a lot of 90s. So that's what you want to see. We want A's for all of our patients in this group. And so I think by the end we feel very good about the regimen overall. There's a couple things I would point out. If you look at the cirrhotic patients who received treatment, it's a very small number of patients. And so when the group of patients with cirrhosis is the group we worry about, and we really want to test all regimens by. And that's been an issue with this regimen. And so in African American cirrhotic patients, we don't have as many numbers. And so this has just been another reminder to make sure that when we're enrolling patients, we're enrolling diverse groups well and thinking about them well. But the big picture is they're doing great. African American patients should be aggressively treated with hepatitis C therapies as well. All right, I've come back to Grasshopper Elzevir. So kidney disease is a group we worried a lot about. So interferon, they didn't do so great with. Ribavirin that we use is renally cleared and it develops severe anemia. So patients on dialysis, I avoided doing it because I thought it was so high risk. Some people did it, but I really didn't. So, and sofosbuvir, which is the drug I mentioned a lot, is renally cleared as well. So it's not a great choice for patients who are on dialysis. It's not recommended. There's no safe dose that's been determined. So this group of patients has really needed help. So this drug, Grasshopper Elzevir is not renally cleared, and this was a very nice and large study, 122 patients. If you notice, like 75% of them are on dialysis. And it's the full analysis set is 94%. If you take out the dropouts, it's really 99%. So it did extremely well, ribavirin-free, well tolerated in a sick population. So knowing that this group of patients has cure is fantastic. So what's next then? Do we need anything else? Are we done? Do we declare victory now? Well, the ideal therapy would be pangenotypic. So we wouldn't even worry about measuring the genotype probably. We'd just give the same to everybody. Really short. We've been a lot of work trying to see how short we can go. I think we're probably at 8 weeks right now. 4 weeks is too short. 6 weeks is probably too short. But 8 weeks I bet we can get to soon. We're not willing to sacrifice efficacy. We want 95%. We want 0 side effects, no drug-drug interactions, and we want everyone to be able to afford it. So that is what we would like. So this is what's coming next month, which doesn't get us there, but I think is trying to make the case for another step. So this is the Astral program, and those of you who work in the trials group here have worked on most of these that have come through DCRI as well. And these are the response rates based upon genotypes here. So, it's so funny when these studies are presented, we spend like the entire discussion talking about the 2 or 3 people who failed. Like what is it about them, what is wrong with them? They must be bad people. The reality is the most common reason why people fail is they don't take their medicine. So that is the most, unfortunately, so we're like bad patient, So it's amazing. There's some issues in here. Genotype 3 cirrhosis group, look, it's 95. That's not good, you people. So we're, because we want everyone. We really want everyone. And if you take that down to the cirrhotic people, it's going to come down further. So we'll see when the FDA looks at it how they handle that. There may even need to be some ribavirin for some of those patients to maximize cure. So there's intricacies in it, but still, now when you're not at 99, you have some explaining to do. Essentially, it's kind of cool. So here we are in 2016. These are all the regimens that are on our highway. I tried to make that on the horizon. I don't know if that worked, but that one's close, and so we've got a lot of things that are here. But what do we do with these regimens? How do we, now that we have these tools, what else can we do? So I think one of the rewarding things for me has been using these drugs in patients who have really advanced liver disease. So that's what we call decompensated cirrhosis. So those are the people who are on the transplant list. And basically, can we stabilize them, save them, essentially? What can we do? We've historically had a high mortality rate on the transplant list. And so those are the patients we're most worried about. So this was SOLAR, which is before Astral, but these are patients with Child-Pugh B and C. So they're really sick. These are people who have a high mortality in the next 3 to 6 months. They need a transplant. And this was looking at ladibosvir, sofosbuvir. The ribavirin, we started at a low dose because we were worried if these people could tolerate it, and they got it for 12 or 24 weeks. On the one hand, this is in the 80s, so I've already trained you that that's bad. But these are people who wouldn't have even been eligible for anything before, right? So the fact that they're even in play at all, was really super, and potentially life-changing. We now look at these slides. The MELD score is a way we assess liver function now. It's a combination of bilirubin, creatinine, and your prothrombin time. And it's how that along with the sodium level is how patients are allocated a liver transplant. So we're also using it to see how do the patients do when we treat them, because we're sort of wondering, excuse me, silence your phones, including me. We're sort of wondering if you get cured, how much better will you get? Will you get all the way better? Will you just get a little bit better? And we really don't know. These studies are following patients until they're 6 months out, and they're getting a little bit better. But we really don't know how much better and what's their quality of life really like, at this point. Those are some questions that we have. We do know that curing people matters. It makes a big difference. It doesn't take everything away. We know this is HCC. It lowers their risk of liver cancer, which is a common complication of hep C cirrhosis. It significantly lowers the need for a transplant. We know that. And we actually have also found it lowers all-cause mortality. So we want to agree, even people with cirrhosis, we know that we can help them. However, we know that their livers aren't completely fine either because they still have a lot of scarring in their liver, and scarred livers are particularly at risk for liver cancer. And this is the study that I quote to my patients all the time and does keep me up at night a little bit. So this was a Swedish registry. And you could say it's only 6 patients, but it's 6 patients, and 3 of them developed liver cancer more than 7 years after they were cured of their hepatitis C. So that's why if you're at that stage of liver disease, even when we cure your virus, you still stay with us, still watch you, still make sure you don't drink too much, still make sure you don't get overweight, still make sure your diabetes is in good shape. So, but it's still a lot better. But it's just not you're completely out of the woods. If we cure you and you had no scarring in your liver or very little scarring in your liver, we wish you well. And I've discharged more patients from my clinic in the last year than I had my previous 15. So it's been really great. But with the patients who have the really advanced liver disease on the transplant list, we really are wondering, where are you? Now, and is there a threshold where we can't avoid a transplant? So even if we cure your virus, are you still going to have be swollen and have all the complications of liver disease? And actually, so there's a registry that's being conducted in this building that is trying to look at this question, and it's really going to take a few years to figure out. I think we're going to have some of the first, just the baseline data cut's going to be, I got to think about an abstract for our society meeting, but we really do need to know what's going to happen to these patients. I care how they're doing 5 years from now. Because if we cure your hepatitis, this is the risk. We cure your hepatitis C, your MELD score, which puts you on the transplant list, what if it just stays stable? I've already seen that a few times. So you don't get high enough where you might get a transplant, but you don't go low enough where you feel great. So we've just kind of left you, which is how one of my patients describes her life. And so have I really helped you? I've cured your virus, yay. but you're not happy. So, and she's got no energy, and she's swollen, and she takes diuretics. And she wouldn't be doing all those things if she got a liver transplant. There's risk of a liver transplant, but at any good center right now, 1 year survival on a liver transplant is 90%. At Duke, I'm proud to say it's even higher. But so there's risk. So we as clinicians are trying to figure out, and this registry is not going to give us data for a few years. So we do have patients now where their MELD score usually is in the 20s. It's the patients around 20 where we struggle, where we say, you know what, we're actually not going to treat you. You're beyond where we think we can help you. We recommend that you just go ahead and get a liver transplant. And then we'll worry about that later. You actually can get a hepatitis C positive organ and reduce your wait time. So that's the dilemma we have currently right now. So then we used to struggle to treat people after transplant. The hepatitis C virus would return in everybody after transplant, and they would get cirrhosis back in 5 to 10 years. So it was not a long-term survival event. But so this is a study that looked as well at patients who had had a liver transplant, and it looked at the full range of patients post-transplant and gave them latibusvir, sofosbuvir, and ribavirin for 12 or 24 weeks. And if you focus over on the left with the patients who don't have cirrhosis, we're up over that 95% threshold. And again, this is a group of patients who was so hard to treat with interferon. They did poorly. Their bone marrow counts were terrible. It was just a disaster. Only when we get out here to Child-Pugh Class C, which we will never let a patient get to again after liver transplant, but do we see a drop-off. But when we are over here, we do well. So we now get a patient transplanted, we let them recover, we get their bone marrow up. 3 to 6 months out from transplant, they go on these medicines and get rid of their hepatitis C. That's a very common scenario for us now. So, and that's something we wouldn't have done. I will say, if any of you saw the dukemedicine.org website in the last couple of years, one of my patients who was in here, he's 41 years old, had a liver transplant, lost it to hepatitis C, and got a second transplant and was losing that liver at 41 years old, cured of hepatitis C. Liver's doing great. Liver's doing great. So, and now we would never let him get that bad. We'd just take care of it earlier. But, still, though he's had a liver transplant, we still would like to avoid that, right? Kidney transplant's the other thing that's been an amazing change for us. So in the past, there's a high rate of hep C in patients on dialysis and patients who need kidney transplants. We're still trying to work through what exactly is going on in dialysis units and why they have such a high rate. Interferon alpha and ribosome were really poorly tolerated, as I mentioned. And if you got to a level of cirrhosis, then you couldn't get a kidney transplant. You had to get a liver kidney transplant. Post-transplant, they wouldn't let us treat their patients because interferon seemed to induce kidney rejection. So the patients were stuck if they'd already had a kidney transplant. So now, because we've got grazoprevir, elbasvir for the patients who have not had a transplant, we've got all the regimens for patients who've had a kidney transplant. So we're actually deferring treatment if the patient wants to get a kidney transplant. Particularly from some racial and ethnic groups, you could wait 6 or 7 years in North Carolina to get a kidney transplant. If you take a hepatitis C positive organ, you wait a much shorter period of time. My most recent patient waited 48 hours. That is exceptional, but she really did wait 48 hours. So, but for some of those patients, the wait would have been years. And so we're now, they get a hepatitis C positive organ. Again, we let it settle in. They've got good kidney function in a few months, and then we cure their hepatitis C. And so we're discarding a lot less organs than we ever did, and it's pretty great. So this is probably the biggest change in our practice over the last couple of years. So we have this talk with them. Are you interested in a kidney transplant? Are you eligible? If you're not, we've got grazoprevir, elbasvir. If you are, we're going to send you to kidney transplant and then have you come back and see us. This was a group of patients we didn't have a whole lot to offer a year ago, and we do now. All right, so how are we doing? We've checked off a lot of groups that are doing well. We actually have a protocol. We're about to get started here. Those same having hep C has been a contraindication to heart transplant and lung transplant because those patients couldn't tolerate interferon. So we're working with those programs, and we're going to start a cohort study that's going to offer these medicines to those patients. The mentally ill, we're not even studying that much because it's just going fine. They have no issues with these new drugs. They're doing great. Persons who inject drugs is probably another area that there's some controversy around, but some parts of the country and the world are aggressively treating that. That is, there's been some modeling data to show that if you want to control hepatitis C in your population, you must get the medicines into this group. The harm reduction strategies do not appear to be enough to impact the spread of the virus, and so ways to treat people who are actively using drugs appears to be key to disease control. So what will it take to cure everyone? Okay, so some of the challenge is there's a lot of people in the world, in the United States and in the world who have this, and most of them are unaware they have it. We think it's 2.7 to 5 million in the US. We know it's higher in homeless people and incarcerated people, and they don't tend to participate in our surveys. So we think we're somewhere in 3 to 5 million, but again, most not identified. There's urgency about this now. Most of these people were exposed in the 60s and 70s between a number of factors, I think, affects that time. Drug use was not quite what it is today, but there was a lot more experimentation with it back then. There was a lot more unsafe sex, and to be quite frank, healthcare was not like it is today as far as the spread of it. So I think that that period of time becomes challenging. What that means is there's a lot of people who've had hepatitis C since the 60s and the 70s. And so they're now getting cirrhosis. It takes decades to get cirrhosis, but we're here. And we've been showing slides like this for a while that suggest there's going to be more and more cirrhosis, because cirrhosis is where all the complications come in, the liver cancer, the transplants, and everything. But we've been saying it's going to get bad, but it appears it's actually getting bad. This was presented at ID Week and has since been published in Clinical Infectious Diseases. But hepatitis C deaths in the United States outnumbered 59 other infectious diseases combined. That includes HIV, Staph aureus, tuberculosis, and pneumococcal disease. So this is what people are dying of. And it's still too common. I will go around to the hospital this afternoon, and it's still too common for me to meet someone who's had a complication of hepatitis C, and that's when we find them, not through a screening program. So we have screening programs. If any of you were born between 1945 and 1965, I hope that your primary care doctor told you that you should have had a hepatitis C test, because that recommendation has been out there since 2012. So surely you all went to the doctor since then and had your test. So why that group? So 77% of all American cases of hep C are in baby boomers, for the reasons I told you about a minute ago, I think, between drug use, free love, and interesting healthcare practices in the 60s and 70s. That's what I'm told. I don't know. I wasn't. Yeah. I'm often on a panel where I'm the only non-baby boomer, and I love to point that out. We do have some other problems, though. So there's been now multiple reports. Hep C is not reportable in every state, but now there have been multiple reports of problems in young people, particularly as we struggle with our opiate addiction issues in the U.S., and some people are turning to injection drugs and heroin and meth. But there have been a number of reports. North Carolina is one of the states. There's 16 states that have been identified as increased risk, and we're one of them. And it's all along Appalachia. So what are the barriers to it? Well, the public doesn't know in general, or they assume it's not really them. Provider awareness is broad. So a lot of people live in places where there's not a hepatitis C specialist for them. Or if you're here, it's a wait to get into our clinics, for example. And then there's money. Can the patients afford the medicines? That's been an issue. So but can we really cure everybody? So the cost has been an issue, and we have really struggled with this helping the patients. That one you see on TV really is $94,500. Granted, not every patient pays that, but a lot of patients hear about that. I have patients who immediately when they hear that number, then I can tell that they're sort of thinking that they won't be able to get it. But it's not every insurance company pays for it at every stage of disease. If you are a Duke employee, you're under this Express Scripts deal where you can get it. You don't get to pick the medicine you want. You're going to go with one specific regimen, but you can get it. But if you're a state employee under Blue Cross Blue Shield, and you have stage 0 or 1, so particularly the younger people, and I see a lot of children of state employees who have hepatitis C, they are not eligible for treatment. Blue Cross Blue Shield will not pay for that. And I don't want to throw Blue Cross Blue Shield under the bus, they're one of the better ones. A lot of the other ones, you have to be at stage 4 to get treated. And our Medicaid gets beaten up because they're not paying for everybody. But again, a lot of the states are covering even less of their population. So it's very challenging. There are ways. Some of the companies have programs to help patients sort of negotiate the system. Our specialty pharmacy helps patients negotiate the system, but it's challenging. And you can imagine, if I've been telling you you've been my patient for 10 years, I've been saying, the drugs are coming, the drugs are coming, the drugs are coming, and the drugs are here, but you don't get one. You can imagine how exasperating that is for some of these people. And I can tell them all day long that you're not near cirrhosis. We do checks on them. You're not near cirrhosis. You're going to be okay for right now. But we all would want to get cured, right, if we knew we had this. And so it's a very challenging scenario. And we have data to show there's other benefits to being cured. All-cause mortality is better. Quality of life is better. I don't think anyone's surprised that the quality of life is better. So it's very challenging. But then let's say we even remove money. Then how would we treat people and where would we treat them? These are places that I have tried to see patients in Durham. So I have gone to the health department, which is lovely if you haven't been down there. If you all know what TROSA is, it's a residential substance abuse program. People go there for 2 years and go through drug and alcohol rehab. And so there's a contained time where they could go. I go there about once a month or so, and all their new people are screened for hepatitis C. It's striking to me as a parent, it's all young people. It's mainly young people. It's 19 to 21-year-olds is the main group that I see. It's all those people I showed you from the Appalachian slide. So it would be great to help those people get their lives. One of the ways to get their lives on track would be to get rid of their hepatitis C. The Durham Medical Center there is where the Duke Outpatient Clinic is. That's where many of our uninsured and underinsured patients within the Duke Health System go. And I would tell you, I've had a couple patients there who the staff there has made it a very supportive environment for people who don't have great financial situations, so that those patients don't want to go anywhere else at Duke. They've usually come to the big house and been treated unkindly, and so they want to be treated there, or or they want to be treated somewhere on the bus line, or they want it to be somewhere by people they know, and so we got to figure out how to do all this. This is Lincoln, for those of you who haven't been there, which is our federally qualified health center in Durham. It would be great to be able to do it there. There's a couple of doctors who would like to do it there. The cost is extreme for them. And they've got competing issues. They're overwhelmed with diabetes and hypertension, and most of the cardiologists in this building would like them to focus on that. So there's a number of factors, but all these issues are at play. So we have to have a treatment plans and models to help them with all of that too. What about the rest of the world? This is me in Myanmar. I am the tall one. We've had the opportunity to go around the world a little bit. I'd like to show this picture. So when I arrived for this talk, there was a man who was pinning up every one of those letters on that curtain. That is all by hand that he did that. And it took him over an hour to do that. I was so touched by it, I took multiple pictures. It's not like he didn't have PowerPoint, and so that's Michael Merson. He runs the Duke Global Health Institute, and Mike is helping Susanna Nagy and Julius Wilder and myself work with the Clinton Health Access Initiative, which President Clinton started after he came out of office, that has done a lot of work in HIV, particularly throughout the world, and bringing care throughout the world. And then the Pharma Access Foundation is a group based in the Netherlands that has done similar work in Africa. They come through very different models. The Clinton group wants to work within the public health sector and build that up and support it. You could see former president liking that. The Pharma Access people really come more from the foundation side and how to do it there. But we're basically helping them in different ways. I did go to Myanmar. Susanna and Julius went to Rwanda and they did a week of training. They trained. What we generally have done is we sit on their national guidelines panels and we train other people to go out and train others in the country. That's been the approach. They're doing it in amazing places, but places that are on the State Department no-fly area that also make us a little bit nervous. But it's been wonderful to try to see how to do that. There's issues though with money though, right? I mean, how will these groups afford it? There are Indian drug companies that are making these medicines much cheaper. Myanmar, they were already in Myanmar when I was there. Not the licensed ones necessarily, so sometimes there's concern about cost, but it's all coming, so how will we do it? But what we've learned a lot is that there's differences when you go throughout the world, and the light areas are where, even though I showed you that slide earlier about how much hepatitis C there is, we really know very little about what it is or where it is. We know in some parts of Asia this is related to the opium trade and things like that. And we thought in Africa it would be related to HIV, and we thought, well, we'll have you piggyback this onto the HIV programs because there's a lot of infrastructure around that, and that will make sense. And the Pharma Access people said that is offensive, essentially, and they're worried. They worry very much that there's such stigma there's stigma with HIV, and there's not stigma with hepatitis C in Africa. But if we base all of our care in the HIV clinics, we just brought stigma to hepatitis C, and so it's all very local politics and culture that we have to basically go country by country to figure out and work with the local doctors. But I think there is one hepatology trained person in Myanmar. There are several in Rwanda. So it's a limited number of people. But it's a lot more about how do you train the right people, and do this in places. We're not going to do this in a tertiary care center. Like we've designed a protocol to try to do this in a district clinic in Kenya, for example. Like, how would you do that? So this is starting to look at that. Oh wait, I messed up one thing on my slide. So this is currently how we do hepatitis C care. And I put this in because one of my points is every time we have a step, we have a chance of losing somebody. Like anytime you make a patient come back to clinic, you have a chance that they don't come back. We see that all the time in the US. But right now you get an antibody test and you come back for an RNA, then you get referred to a provider, then they do an assessment on you and get more labs. Then they either get a biopsy or an elastography, they get you some prescriptions, maybe you don't get them, maybe that's why I have that there. Then you get treated for 8 to 24 weeks. Some of you are cured, some of you fail, and maybe we consider retreating you. If you had a lot of scarring, you still got to stay with us. So that's a little bit complicated for basically a health administrator in a rural district clinic in Kenya to do. So Mike Merson has been great about really challenging us. We're so used to our perfect model, and he's really made us look at how would you do this more simply? How could you do this in a way that could be reproduced? And he made us cut out all these things, and got us down to this essentially. But in it, we need to know more about the epidemiology. If we have all genotypes that are really treatable, maybe we don't have to check the genotype in that area. I will say the other thing we've learned through this is that the diagnostics in hepatitis C were came along much more slowly than the therapeutics. And that's really hurt us. We don't have great field diagnostics and things like that. We have blood spots for antibody, but we really don't for the rest. But if we could get to this, then what we thought is that the other thing we do is if we give them some clues to identify patients with cirrhosis and say, don't do that. But if patients don't have advanced cirrhosis, let's do all this. And then you can really impact things more and potentially save a lot more people. And so this is basically the protocol that we are sharing in some of these, particularly the lower income countries that are going to have limited resources. And this is what we're suggesting. So anyway, so that's the end. I'd like to thank you all for coming again. This has been an amazing, the pace of change and improvement in this disease has been more than I could have expected. That's why Brad said I've had to go look for other diseases to work in because hepatitis C is not going to be here for my entire career if I'm going to do any research, and that's a good problem. We can cure almost everybody, but it's really now more about getting the patients the medicines, and that's a great problem, but it's still a big challenge for us. I did want to just thank you all, and I want to thank a couple people really quickly because I don't get to speak to an audience very often, but John McCutcheon trained me here, and he's always in our memories when we're working here. Eric Peterson has been great, very supportive over the last few years as we've tried to build up the program as well. Danny Benjamin also from the clinical trial side. Chris Noberi answers every email I have about how to think through DCRI and to make it a supportive place for faculty. Sarah Hollard helped me tremendously last year in thinking through the strategy for all this. And I also like to thank my faculty I work with, Susanna Nagy. Deborah Fisher just joined in GI, and I hope many of you all have met her. Julius comes in July, so we're trying to beef things up a little bit. And lastly, particularly the HCV RNA monitoring group. I mean, Stephanie's here, John McNeil, Duncan's in, I think I saw Duncan. There's a number of people that really came together from a number of aspects of DCRI and sort of showed me what this place could do, and it was really great. So thank you.
Thank you so much, Dr. Mir. I didn't know if there were any questions out there. We have a few minutes for some, sure.
Just out of curiosity around the cost that's related to the intellectual property and the patents, what time frame will some of these drugs start coming off patent where the costs will come down?
I'm not exploring that, but it's years. It's years. But there have been licensing. I think the key is actually there's licensing agreements to do it in some of these pharmacies throughout the world. That's probably how the prices already come down significantly in the low and middle income countries. But in the U.S. we're talking about years. So not. 10. There's an interesting, some of the people who developed Vertex, that company that did telaprevir, are working on taking some of the failed drugs that failed for a number of different reasons and they have some, what do they call those, angel investors or whatever, which I'm really interested to see how that goes, but they're sort of trying to see what they can do because they're not trying to make as much money as possible. And they had one of their first presentations at our recent European meeting, but just basically to see what they can do with drugs that have been shelved, essentially, just to sort of see what value can be obtained in those. So there's some interesting things around it, but the market forces are coming. That last regimen that I mentioned, Griselprevir, Elbrazvir, was priced down. It's all, but not, I think, to the degree that Bernie Sanders would like, and that we wish we could have, so you wish you weren't struggling with this kind of dilemma. But yes.
So what is the shortest treatment duration to use this medicine?
So what's the shortest treatment duration is the question. So it's been studied as short as 4 weeks, and that did work in selected patients, but not in enough patients to feel like that would be okay for the regimen that we have. It looks like the sweet spot with the current drugs we have is 8 weeks. And there was even a presentation at our European meeting for genotype 3s, our hardest treatment. our hardest genotype to treat. A new regimen at 8 weeks looked great. No ribavirin, it looked great. So I bet we probably have other regimens bring us all down to 8 weeks. And I didn't mention, there's still other drugs in development. There's going to be a next generation of elbasvir, and there's some other companies coming into it as well. We're not done. It's just we no longer have 50 companies working on it like we did, 10 years ago. We're now down to like 5. Somebody back?
Yeah. Would you consider, or are we already doing like transplanting HCV positive donors into negative patients?
So the question is, would we transplant hepatitis C positive donors to hep C positive, hep C negative patients? So that has been done in selected ways in livers. And so we've already talked as a transplant team. We would do that here. We have this occasional scenario where we have somebody in a fulminant situation. So they've taken a drug, some kind of scenario where their liver is on the clock and it has hours. They move immediately to the top of the transplant list, but that is the scenario by which we really could lose somebody. So we have talked that we would offer that to a family if we were in that situation. And I know of a couple other centers that have done that, and I have zero qualms about that. I did talk to one of the other solid organ programs. They actually came to me about this. Was this something to consider? I think with a whole lot of consent and discussion and things like that, I think it potentially is. But if there's a donor shortage in any of the other organs, I think it's definitely reasonable. There's risk to it, but there's risk to not, as we know, there's risk to not getting transplanted in some of these conditions.
Do you see any effects of immune suppression long term with cure or anything like that?
Any effects of
like chronic immune
relapse,
suppression?
you mean, or something like that?
Relapse.
Late relapse? No, we haven't. This is not like hepatitis B. The late relapse has been at a year late in very selected cases. We see reinfection occasionally, but we don't. It's not protective immunity. I don't like, but this is not like rituximab where you might give for their hepatitis B could reactivate decades later. This is not like that at all. When you're cured, it's gone. So, which is great.
One last question.
Yeah, so we've gone from identification of the virus to cure in 25 years. So what do you think, why did this happen in hepatitis C and not in other things like HIV?
Thank you,
what
Sam.
made it special?
Why did this happen in hepatitis C and not in HIV? Well, probably because the virus doesn't get incorporated into the genome. And like hepatitis B, that's been our big challenge in hepatitis B. It's the way it interacts with our immune system is different, thankfully. I will say, I think the reason why that it happened so quickly, though, is a little bit of the stories I told, but when this went, effective partnerships in industry were key here. This went, nowhere at the NIH, and only when pharma got heavily involved and then it worked effectively, this went very rapidly. That group at Pharmasset that then sold the drug to Gilead, they were very dynamic and novel, and really, that made the whole field move faster in a competitive environment. And they had different academics engaged in it. But it was, every industry trial went, 3 years before the NIH was even, moving. And it's just, not criticism of those people, but it took that this was our economy that's fine. It was partly why when everyone talks about the $95,000, I'm a borderline socialist, but I personally wish it didn't cost $95,000. But if they hadn't done that, my patients would still be dying. This is America. This is American capitalism at its finest. It paid off. So. Because when I lecture to the first year medical students, you can imagine the outrage, about about the $95,000. And I appreciate the black and white nature of being, I used to be that way too, But after 10 years of watching patients die, I was grateful that that a drug company did this. So.
Let's thank Dr. Beard.